Hi there. My name is Hassan Salam. I'm a professor in obstetric gynecology and reproductive medicine at Alexandria University in Egypt. And today I'm going to talk to you about the polycystic ovarian syndrome, its pathophysiology, diagnosis, and treatment. Now, why do we call it a syndrome? Because it is not a disease. A syndrome is a set of medical signs and symptoms which are correlated with each other and often associated with particular disorder. So it comes from the Greek word syndromon, meaning concurrence. So we can't really put our finger on a particular cause. This is why it is a group of symptoms and some signs. بالعربي متلازمة. The first person to talk about this syndrome was probably Antonio Vallisneri, who was a professor at the University of Padua in the 1700s, and he described a married infertile woman who had shiny ovaries with a white surface and the size of pigeon eggs. But really, the credit usually comes to Stein and Leventhal, who in 1935 described women who had, on examination, infertile women. They were infertile, they had irregular cycles, and when they came for examination and they had a vaginal or by manual examination, they could see that they had 3 lumps, which turned out to be the uterus and 2 big lumps, both ovaries. And when they did the laparotomy, they found this picture, so they removed part of the ovary, a wedge resection, and this is what they saw under the microscope. So they said maybe this wedge resection will treat these women. In fact, some of these women became pregnant, but not all of them, and they may have had some regular cycles for some time, but then things reverted to what they were beforehand. With time, people discovered that some of these women had hirsutism and acne, and also some of them had insulin resistance. Not all of them, but about 2/3, 64.4 in this study. Some of them more recently, it was discovered that AMH levels in the serum and in the follicular fluid of women with PCOS was elevated, as you can see, comparing the left side to the right side. It was also shown, as you can see, that 60% of these PCOS women had an elevated serum AMH between 4 and 11 nanograms per milliliter. And in fact, 23.5% had a very high level, more than 11 nanograms per milliliter, while only 16.5 had levels of less than 4 nanograms per milliliter. So, with time, people realized that the polycystic ovary syndrome had many of these things in common. These women had polycystic ovaries. They had a high LH compared to FSH. They had hyperandrogenemia. They had increased insulin. They had increased AMH, and they were very prone to OHSS. Not all of them had everything, but many of them had many of these symptoms and signs. And of course, when they had induction of ovulation, some of these women developed what we know now as the ovarian hyperstimulation syndrome. On the left, of course, this is before people understood what the ovarian hyperstimulation syndrome was. In this case, they opened the abdomen trying to help this woman, and on the right side, we know how to see this with ultrasound. So how do patients with PCOS present? They either come because a young girl has irregular cycles or amenorrhea, or they come because this girl has hirsutism, or they come because a married woman is suffering from infertility. So when we examine and we find that some of these women had insulin resistance, some of them have thin hair and hair loss, some have acne,
some have weight gain, and if we do our tests, we will find that the polycystic ovaries can be seen on ultrasound, and in the laboratory, high AMH is found in the peripheral blood. How prevalent is PCOS? Well, to make it simple, it's 1 in 10 women, when 10% of women may have PCOS. 70% of them had not had it properly diagnosed. Less than 50% are properly diagnosed, and more than 50% will have diabetes before the age of 40. So, what is the etiology of PCOS? There are 3 common theories. The first one is that PCOS is due to hypothalamic pituitary dysfunction. The second is that PCOS is due to ovarian and adrenal hyperandrogenism. And the third one is that PCOS is due to a disorder of peripheral insulin resistance. And this is a summary of the different theories underlying or explaining the development of PCOS. The first one is the hypothalamic pituitary dysfunction, which was proposed by Samuel Yan and Robert Jaffe. Robert Jaffe, of course, the professor of UCSF, University of California, San Francisco, and Samuel Yan in UCSD, University of California, San Diego, many years ago when they produced this book, which is now written by Jerome Strauss and Barbieri. In this book, they showed this diagram on the right side, showing that in the theory, LH stimulates the theca cells, producing androgens, as we all know. So this diagram shows a follicle with cells inside the follicle, which are the granulosa cells, and cells outside the follicle, which are the theca cells. So the LH stimulates the theca cells, which produce androgen. These androgen, in order to become estrogen, or more specifically estradiol, they have to go inside the follicle, because this is where the enzyme aromatase is present in the granulosa cells. So a disturbance here will lead to the polycystic ovary syndrome in the opinion of Jaffe and Yen. Another theory says that the real reason is insulin resistance. It starts with insulin resistance, which produces excess circulating insulin, and then the rest of what happens with the hormones and the other symptoms can be explained primarily by this insulin resistance. Another theory advances that it is all due to hyperandrogenism, which produces the polycystic ovaries, the anovulation, the hirsutis, the acne, and so on. Another theory says that obesity is the real cause, especially visceral obesity, and this goes into this cascade and ends up by the full-blown syndrome as we know it. The role of the environment also has been mentioned, or at least a mixture between genetics, environment, and central obesity, leading to insulin resistance, hyperinsulinemia, hyperandrogenism, in turn leading to polycystic ovary syndrome with hirsutis, amenorrhea, infertility, and dyslipidemia. But with more and more research, it was shown that there are some genetic associations in PCOS. Cooper et al. Supported the hypothesis of autosomal dominant inheritance because in 1993, monogenic causes of hirsutism and oligomenorrhea in these women started to be identified. In twin studies also, it was shown that there is an X-linked polygenic disorder.
But really, the most logical theory is the following: anti-Mullerian hormone. Anti-Mullerian hormone is called anti-Mullerian hormone because it stops the Mullerian duct system from developing in the fetus. Anti-Mullerian hormone. Beforehand, it was called Mullerian inhibiting substance, MIS, or Mullerian inhibiting factor. Now it is called AMH, anti-Mullerian hormone. And as you can see from this structure on the right, the gonads in the fetus, early in fetal life, the fetus is not yet does not show yet if it is going to be a boy or a girl. This is very early. The gonads, as you can see them, and then we have the two duct systems. The red one, which is the Mullerian duct system, and the blue one, which is the Wolffian duct system. And of course, if this fetus is going to be a female, the Mullerian duct system will develop into the tube, the uterus, and the upper fifth of vagina. While if this fetus is going to develop as a male, now the Mullerian system is going to disappear, as we can see on the right side, lower right side, with the blue, all blue, and this is because the Mullerian system has disappeared, atrophied, and what has developed now is the Wolffian duct system, producing the male duct, seminal vesicle, prostate, and so on. So, if we leave the fetus altogether, it will develop into a female, unless there is AMH. If AMH is produced, then it will be anti-Mullerian hormone. It will stop the Mullerian system from developing, and therefore the fetus is going to be a boy. Another diagram showing the same thing is that at the beginning, the yellow are the gonads, and then we have the red Mullerian system and the blue Wolffian duct system. And as you can see, if the baby has a Y chromosome, then there is a sex-determining Y gene on the short arm of the chromosome 11 called the SRY gene, sex-determining Y gene. And as you can see, this gene actually stimulates, if in the Y gene, it stimulates the gonad to produce AMH. It is going to develop into a testis, and from the Sertoli cell of the testis, AMH is going to be produced, and it will suppress the Mullerian duct system, and the fetus is going to be a boy. So the theory in PCOS is that at this stage, these girls who are going to be polycystic ovary patients in the future have had some disturbance they should not have any AMH in fetal life, but apparently they have part of this AMH in fetal life, or some sort of disturbance in the genes with expression of AMH early in fetal life, and which can continue with them until they grow and become PCOS patients. And let me remind you of the hormonal interactions. Now, if we look at the upper part of this diagram, we will find that cholesterol, which is composed of 27 carbon atoms, when it goes inside the ovary, 6 carbon atoms are going to be taken away, acetoacetic acid. And what remains are progestogens, a group of hormones collectively known as progestogens. The most important of them, of course, is progesterone. But we have also its cousin, pregnenolone. And as you can see here,
they are formed of 21 carbon atoms. If you look at the left part of this slide, you can see the numbering system of this steroid ring, as it is called. The steroid nucleus, which is composed of 4 rings, A, B, C, D, and normally it will stop at 18, but we can have also 19, 20, and 21. So at the left side we can see progesterone, because it is composed of 21 carbon atoms, progestogens in fact. Progesterone, on, which means that it contains a double bond O, as you can see here in the position 3. What is the difference between pregnenolone and progesterone? Is that the double bond starts at position 4 in progesterone and position 5 in pregnenolone. Therefore, this is why the left column is going to be called the delta 5 system, and the right one is going to be called the delta 4 pathway. Then, if you remove 2 carbon atoms from the progestogens, you get the group of androgens, which consists only of 19 carbon atoms, because as you can see here, number 20 and 21 have been removed, and we are left with the androgens. Androstenedione, dione, 2 double bond, or androstenediol, 2 ol, 2 alcohol, 2 OH. So these are the androgens. The next step is the formation of estrogens, the green ones here. And as you can see here, number 19 carbon atom has disappeared, and now the estrogens contain 18 carbon atoms. The estrogens, the important one for us, of course, is the estradiol, because this is the one responsible for ovulation. But estrone also is produced, and it has some importance in the menopause. Well, estrogens have a nice odor. They are aromatic. This is why the enzyme that does this is called the aromatase enzyme, or the aromatase enzyme system. And here are the estrogens. As said, estradiol, 2-OH, and estrone, on, double bond O. And there is the estriol, which is produced from the placenta, 3-OH, estriol. And as you can see, what happens in patients with polycystic ovary syndrome is that because they have an elevated anti-melanin hormone, this stops the aromatase system from working. So there is little transformation from androgens to estrogens, and there is an accumulation of androgens, hence the hyperandrogenism, and there is little estradiol, hence the lack of ovulation. This can also be explained in the so-called two-cell 2-gonadotrophin therapy. As you can see on the left side, these are the theca cells, which are outside the follicle, and then on the right side, you have the granulosa cells, which are inside the follicles. And as said, the LH stimulates the theca cells to produce progesterone, progestogens, and then androgens. And then these androgens will go inside the granulosa cell, but they can only be transformed into estrogens under the effect of FSH. FSH stimulates the system in the aromatase system inside the granulosa cells, and only inside the granulosa cells, to produce the 17-beta estradiol, as you can see here. Well, the hormone that does this is, or the enzymes that do this, is the aromatase enzyme system, also called P450 aromatase. Now people ask,
So, what is PCOS? How would you define PCOS? There were many attempts. The first attempt was by the National Institutes of Health. The National Institutes of Health, not one institute, there are actually 31 institutes, and one of them, which is active in the area of human development, fertility, and child health, the Eunice Kennedy Shriver National Institute of Child Health and Human Development, the NICHD. So what they have proposed in 1990 is that this syndrome should be diagnosed when we have oligoovulation and signs of androgen excess, after exclusion of other disorders that can result in menstrual irregularity and hyperandrogenism. Observe here that there is no mention of ultrasound. Ultrasound is not necessary for the diagnosis. The Europeans, of course, who had already invented ultrasound in Scotland by Ian Donald, they said, how come we cannot really take this diagnosis like this? Because when we do ultrasound for these women, we see that they have many follicles. They may have 20 or more for small follicles between 2 and 9 millimeters in at least one ovary. They have a large ovarian volume also. And when we examine with 3D or 4D, we can measure the volume of the ovary, which is increased in these patients. So what happened is that the Europeans and the Americans sat together in the harbor city of Rotterdam, and they had this consensus in 2003. Which says what? They put everything together. They said, okay, diagnosis should be confirmed by at least 2 out of the 3 criteria. Oligoovulation, biochemical or clinical signs of hyperandrogenism, being it biochemical or clinical acne, hirsutism, acanthosis nigricans, and biochemical an increase in testosterone, androstenedione, and dihydroepiandrosterone sulfate. And the third criterion is the polycystic ovaries on ultrasound, showing more than 12 follicles, small follicles in each ovary, or an ovarian volume of 10 milliliter cc. Then came the Androgen Excess and PCOS Society in 2006. They said no, PCOS should be considered a disorder of androgen excess from the beginning. And our definition is going to be on clinical biochemical evidence of hyperandrogenism, on the evidence of ovarian dysfunction, oligoovulation, anovulation, polycystic exclusion of related disorders. And this, of course, depending on the definition you use, you can have a different preference then. But later, in 2010, the Society of Obstetricians and Gynecologists of Canada made a very logical definition. So they followed the Rotterdam criteria, which is at least 2 of the following 3: oligoovulation and ovulation, clinical biochemical evidence hyperandrogenism, polycystic ovaries on ultrasound. But they added, you have to exclude other causes of hyperandrogenism, like congenital adrenal hyperplasia, androgen-secreting tumors, and the Cushing syndrome. So what is this congenital adrenal hyperplasia, also called adrenogenital syndrome? These young girls really have low plasma cortisol. This is the problem which they have. And they have other things, of course, but mainly low plasma cholesterol. Going back to our diagram, as we showed before, cholesterol in green, which has 27 carbon atoms, goes into the blood. Then progesterone is produced after removing of 6 carbon atoms. You have the progestogens that we see 21. Then you remove 2, you have your androgen, C19 in green. And then you have the aromatase system, which removes 1 carbon from the androgens giving you the estrogens. But this is not the end of the story, because there is also a side channel which produces cortisol, and this comes from 17-hydroxyprogesterone through two enzymes, the 21-hydroxylase enzyme and the 11-beta-hydroxylase enzyme. So if these two enzymes are not functioning properly, then we will not have cortisol or corticosterone. And here is what it is. If we have a problem with the 21-hydroxylase or the 11-beta-hydroxylase, then we will have low plasma cortisol. And the 17-alpha-hydroxyprogesterone is going to accumulate. And the metabolite which goes in the urine is the pregnant triol, not diol. Diol is the metabolite of progesterone, but the metabolite of 17-hydroxyprogesterone is a pregnant triol, which will be elevated in this case. The other thing that needs to be excluded are the androgen-secreting tumors of the ovary, like this Sertoli-Leydig cell tumor, as you can see. It produces androgens from remnants, as said, of the Wolfram system, probably, and then these will lead to androgenism, as you can see on the left side, and sometimes clitoromegaly and things like this. The third thing to be excluded is the Cushing's syndrome. As we know, this is due to a disturbance in the production of corticotrophin releasing hormone coming from the hypothalamus, an increase in this hormone which produces an increase of ACTH, leading to the full blown picture of Cushing's syndrome, buffalo hump, hypertension, decreased libido, purpura, muscle wasting, moon-like face, chest-like hump, chest-like nipples separated, depression, abdominal stretch marks, and so on. So, because of this confusion, in 2012, a panel met the so-called NIH evidence-based methodology workshop panel. And what they suggested is that you either rename the disorder completely, or maybe we should add some phenotypes. And this is what happened. People started to talk about 4 different phenotypes. Phenotype A, where you have the 3 criteria: oligonucleation, hyperandrogenism, and the polycystic ovaries. Phenotype 2, you don't have polycystic ovaries on ultrasound. Type C, you don't have oligonucleation. You have cycles here are regular. And type D, you have no hyperandrogenism. So the full-blown picture really is in the A criterion, is the phenotype A. And this is the classification in different countries: Italy, Turkey, Brazil, Mexico. But does it make any difference? To give a short answer, no, it doesn't seem so far that these phenotypes are going to change our management. Another thing to remember is that PCOS has consequences, short-term ones and long-term consequences. The short terms is that it is associated with obesity, of course, infertility, irregular periods, abnormal lipid levels, hirsutism, acne, androgenic alopecia, glucose tolerance diminished, acanthosis nigricans. All these are short-term consequences that you can see in your patient immediately. But there are also long-term consequences. There is an increased risk of developing diabetes mellitus, endometrial cancer, and cardiovascular disease. The metabolic syndrome, in short, as you can see on the right side, because the metabolic syndrome is 5 things really: insulin resistance, visceral obesity, hypertension, high triglyceride, and low HDL cholesterol. So how shall we manage PCOS? Well, the management, because it is a syndrome, the management depends on the symptoms. If the patient is coming complaining of irregular cycles, okay, we will do something. If she's coming mainly for hirsutism, we do something else. If she's coming for infertility, we do something else. And at the same time, we have to remember the long-term effects. So, irregular cycle. A girl comes and she says, or a newly married who doesn't want to have children, comes to your clinic and she says, I have irregular cycles. So what? We do our tests. We discover that she does not have ovulation or she has irregular ovulation. So first treatment is no treatment. And many people accept this, particularly young girls, because they don't want to be labeled from the time they're really young. The other method is to do progesterone withdrawal if the cycles are delayed and irregular, so we can give progesterone and do withdrawal. But some people want to have their cycles regular for the long term. They say, well, I want to have regular cycles like my friends. I want to have regular cycles. We say, okay, we will give you cyclic hormonal therapy. So progesterone withdrawal is to give progesterone or progestational substance which resembles progesterone in its action, and then we stop it. Then we will have a withdrawal of progesterone which will lead to endometrial separation and starting menstruation. And these are the different these are the progesterone preparations, not the progestrogens. This is the progesterone, which can be given in a micronized form. And there is also the dydrogesterone, which is an isomer of progesterone. Then we have the 19-nortestosterones. Now we have also, these are all given by oral preparations. Then we have vaginal preparations, which are the micronized progesterone. Again, the same one can be given orally but vaginally, the progesterone gel and the progesterone suppositories. And then we have the intramuscular preparations, which usually consist of estrogen and progesterone. So you give any of these preparations and stop. After a few days, the patient is going to start menstruating. We talked about progesterone. There are also the progestogens, or in America they call them progestins, and in Europe they call them progestogens, which are substances resembling in the action of progesterone. And these can be prepared from compounds which contain 21 carbon atoms or 19 carbon atoms, 19 nortestosterone. So it means that we remove the carbon atom in number 19, ending up in what we call the estranes because they contain 18, or another carbon also leading to gonanes. And then we have the spironolactone, like the drospirenone, used in oral contraceptive. They are all used in oral contraceptive, in fact. But the most commonly used one for withdrawal bleeding or for regulating the cycle is the medroxyprogesterone acetate, as you can see on the left side. 5 milligram tablets, you give them twice a day, and then when you stop, the woman is going to have to start menstruating. Other preparations are the cyclic hormone therapy, which means what? Giving estradiol, then progestational material. Estradiol, usually estradiol valerate, 0.2 milligrams tablets for 11 days, and these are followed by norgestrel, which is a progestogens, 0.5 milligram tablets for 10 days, and then you wait. The patient is going to have her menstruation, and then if you like, you can repeat this multiple cycles, but eventually the patient is going to revert. If when you stop, she's going to revert to irregular cycles. And instead of giving this, which contains a large dose, as you can see, 0.2 milligram tablets of estradiol and 0.5 of norgestrel, we can simply use the oral contraceptive, combined oral contraceptives, which contain ethinyl estradiol, now in 30 microgram, that's all, and levonorgestrel 150 picogram. So they contain a much smaller amount of the hormones, and they are going to give the same effect, particularly if the patient is going to use them for a long time. So we said that the management depends on the presentation. If the patient comes suffering from irregular cycles, we said what we're going to do. If she comes suffering from hirsutism, so there are 3 lines of treatment: medical management, cosmetic and hair removal, and lifestyle management. So first thing, the medical management, and again, we can give the oral contraceptives. We can give anti-androgens, particularly spironolactone and cyproterone acetate, and there are oral contraceptives which contain cyproterone acetate. So in this case, the patient will benefit from regular cycles and also from diminishing this hirsutism. And it's also a cream which is applied topically to slow the growth of unwanted hair. And finally, we have the insulin sensitizers, which some people believe, like metformin, but some people believe that it will improve hirsutism besides improving insulin resistance, of course. The other thing are cosmetic and hair removal methods, and 2 of them are supposed to be permanent: electrolysis, which destroys the hair follicle from its bases, and laser hair removal. But there are methods which are really temporary, like waxing, plucking, shaving, and bleaching. These are all temporary options. And as said, lifestyle management, weight loss, and exercise. The third presentation is when the patient comes suffering from infertility. So what should we tell her? Lifestyle management. We then try to induce ovulation, because this is her main complaint. Of course, we have to make sure that the semen of the husband is of good quality and that there is no obstruction in the tubes. If ovulation induction does not work, we may combine this with intrauterine insemination. And if it doesn't work, we will do IVF and or ICSI if the semen is abnormal of bad quality. So these are the steps. Lifestyle management. Few people, of course, will accept to change their lifestyle for, say, 6 months. They're coming, they want to have pregnancy very quickly. So this can be done in parallel with ovulation induction. So ovulation induction depends, we can look back at this functional classification of ovarian disorders, which was advanced by Professor Bruno Lunenfeld when he was the chair of the WHO Scientific Committee. So under this classification, we have Group 1, Group 2, and Group 3. Group 1 are patients who we call hypo-hypo. They don't have no FSHs coming from the pituitary. So the FSH and LH are very low. And if you give them FSH and LH, they will ovulate. If you give them clomiphene citrate, they will not ovulate. It is not a dysfunction, it is an insufficiency, and usually they present with amenorrhea. The third group are patients who are in premature menopause. They have amenorrhea, yes, but they have high FSH and high LH. They have already entered into the menopause even if they are young. But the group 2 are patients who have hypothalamic pituitary ovarian dysfunction. So the ovaries are not functioning properly, but they are capable of doing so. So we have the classical type, the patient, but we have, more importantly, we have our syndrome, the polycystic ovary syndrome, where the patients have usually irregular cycles, although on some occasions they may have amenorrhea. There's a group of hyperprolactinemia, and also the group of congenital adrenal hyperplasia, as we said, where the treatment will be to give them cortisol. But let's stick to our syndrome, the polycystic ovary syndrome. So what do we do to to induce ovulation in these patients? Well, induce ovulation. But how will we know that ovulation has happened? We measure progesterone in the mid-luteal phase. And this is the work that I had the pleasure of doing when I did my PhD in the University of London in 1983, where I did measure the plasma progesterone levels and many other things. This is different from the PhD I did in Alexandria University, of course. But when you came back, in fact, we published this paper, when I came back, I published this paper on fertility and sterility in 1999 about the reference values, because the patient will do the test of progesterone. She will come to you. She will say, okay, doctor, is this test good or bad? So what we did, to cut a long story short, is a retrospective analysis of patients who became pregnant, those who did not become pregnant, and found that a woman must have at least 10 nanogram per milliliter in the mid-luteal phase to become pregnant. Also, my work in this PhD involved also the measurement of progesterone in saliva. Of course, it's very small amounts, some picograms, and also the estradiol in femtograms, and also one can measure the metabolites in urine, the pregnenolone, alpha glucuronides, as you can see here, but usually we only measure progesterone in blood, and we want it to be more than 10 nanograms per milliliter. Although when patients become pregnant and the pregnancy continues, it is usually more than 15 nanograms per milliliter. And this is the paper I was talking about. So if we have low progesterone, the patient has she has poor ovulation, and if she becomes pregnant, we will have to give her one of these drugs: clomiphene citrate, letrozole, tamoxifen, and sometimes people give metformin. So clomiphene citrate, if you probably know, it was developed by a company which thought that they were developing a contraceptive. But when they gave it to the patients had increased fertility rather than diminished fertility. So it started to be used for ovulation induction by Professor Greenblatt in Atlanta, Georgia, and then now it is very common. So when he started using it, he was afraid of giving it on the first day of the cycle, because he was afraid that the patient would become pregnant and blame him for any congenital anomalies. So he would wait until day 5 and then start the clomiphene. As you can see here, the clomiphene citrate produces an extra in the upper part of the right side. The green is the LH and the yellow is FSH. There is a peak which develops between day 5 and 9, and then another peak on day 11 and 12, which produce ovulation. While on the lower panel, this is what happens in normal cycles. And does clomiphene really work? And the short answer is yes, of course. And there is a Cochrane review, in fact, by Hughes Italia, showing that this is the result. Yes, if you use clomiphene citrate versus placebo. And this is a more recent Cochrane review, as you can see here. Yes, the clinical pregnancy rate, if you use clomiphene citrate versus placebo, is increased at least 5 times, about 6 times really. Letrozole is also another drug to be used, which can be used. And as you can see here, again, letrozole versus clomiphene citrate in this Cochrane database shows that letrozole is even associated with a higher live birth rate compared to clomiphene citrate. Also, if clomiphene citrate does not work, then we will have to resort to gonadotropin therapy. And as you can see here,
yes, gonadotropin therapy will give you a higher live birth rate compared to clomiphene citrate. And what is gonadotropin therapy? It started, and as you see on the left side, by the so-called menotropins. They were isolated from the urine of menopausal women because they contain high FSH and LH. So they were used, these preparations containing 75 FSH and 75 international units of LH. But then the drug companies realized that women with polycystic ovary syndrome develop ovarian hyperstimulation syndrome. And this is mainly because they have already a high LH. So they started to diminish the LH in their preparations by removing, instead of 75 and 75, it would be 75 FSH and 25 only LH, the purified gonadotrophins. And then after this, they did the highly purified gonadotrophins, which contain 75 FSH and less than 1 LH. And finally, of course, we have the recombinant preparations, which are pure FSH with no LH content. At the beginning, and this is again from my work in the United Kingdom for my PhD, I used to stimulate the patients with HMG and follow this by measuring estradiol in blood, because at that time ultrasound scanning of the follicles had not started. But when we started doing ultrasound scanning of the follicles, I shifted to, of course, to monitoring with ultrasound, as you can see on the right side. And in fact, we published the first paper on monitoring gonadotropin therapy by ultrasound without hormones, published in the British Journal very early in February '82. But it was clear again from the beginning that patients with group 1 had better success rates, the patients who are hypo-hypo, while the patients with group 2, including polycystic ovary syndrome, had a lower pregnancy rate, as you can see here. And the line in the middle is the fertility of the normal population. So it was important to prevent ovarian hyperstimulation syndrome, because it was seen that if you give HMG to polycystic ovary syndrome patients, they can develop the ovarian hyperstimulation syndrome, and in different degrees, of course. And why is this? Because it stimulates the formation of VEGF, vascular endothelial growth factor, which makes the blood vessels permeable to the plasma, which then migrates to the third compartment. They can go to make ascites, they can do pleural effusion, and they can do edema in any part of the body, including the brain. And of course, they can also be associated with the blood becomes very thick, and then we may have thromboembolic events. So as you can see on the left side, at the lower end, there's compartment syndrome, which means that the fluid migrates to the third compartment. This can also affect the liver and the renal impairment and adrenal impairment of gas, in fact, and also thromboembolic events. It can be very serious. Deaths have been recorded, very few, but recorded. So what should we do if we are giving the patient HMG or FSH, and we can see that she's about to develop FSH, ovarian hyperstimulation syndrome, OHSS? The first thing is to cancel the cycle. We don't give HCG. But sometimes the patient had received a lot of treatment, expensive treatment. So in this case, we may trigger, instead of giving LH, we give the GnRH agonist trigger. And then we give dopamine agonist. We know that dopamine prevents ovarian hyperstimulation by a different mechanism than hyperprolactinemia.
then metformin are also thought to diminish the incidence of ovarian hyperstimulation. And if we are doing IVF or ICSI, we will not replace the embryos in the same cycle. We will do freeze-all, freezing all the oocytes, the freeze-all policy. And then, of course, from the beginning, if we think that this patient is a polycystic ovary syndrome, so from the beginning, we should give her a GN antagonist protocol rather than the agonist protocol. There is also something that has been described by Orvieto and Homburg. They said that if we are going to induce ovulation, not for IVF, but just to induce ovulation, so maybe we can start by a small dose, the so-called chronic step-up FSH protocol. We start with a small dose, half an ampoule, 37.5, and then we do an ultrasound on day 7, then on day 14. If it's no good response, we increase the dose slightly by 50% for another week, and then we do another scan on day 21, and we will give the SCG 5,000 international units only, not 10,000, whenever the follicle reaches 16 millimeter. I would say more than 16 it depends on the calibration of your machine, really, but mainly it will be 18 millimeters. And this is what Orvieto and Homburg showed, is that if you do this chronic step-up protocol, you have 0 incidence of ovarian hyperstimulation. Of course, they are experienced people, and you can see that the study is a small study, 25 patients versus 25 patients. So we do ovulation induction. If the patient does not become pregnant, what do? We may combine this with intrauterine insemination. And as you can see here, intrauterine insemination is better with stimulated cycles. As you can see, the upper panel shows clomiphene citrate. And what is significant, I put in red. What is insignificant, I put in blue. So clomiphene citrate does not really improve things. IUI with clomiphene citrate is like IUI without anything. But the second part, the second panel, is gonadotropins. If you do IUI with gonadotropins with FSH, now we have a much better live birth rate, significantly better, higher, as you can see here. And if we calculate them together, you find that yes, in short, stimulation with IUI is better than no stimulation with IUI. Then if you do IVF, as we used to do many years ago, I had the honor and pleasure of being in charge of the infertility clinic at King's College Hospital since 1979, under the chairmanship of Professor Stuart Campbell, the godfather of ultrasonography. When we started the program in 1981, there were less than 15 programs in the world, less than 40 clinicians who could do IVF, and certainly less than 10 who could do transabdominal ultrasound-guided oocyte retrieval. Because at that time, vaginal ultrasound was not invented yet. Professor Robert Edwards, the godfather of IVF, is a very good friend of ours, was a very good friend of ours. In fact, he came to Egypt 3 times. He came to Alexandria, not to Cairo. He visited Cairo on the 3 occasions, but his conference was in Alexandria. 18 years of IVF in 1995, 25 years of IVF in Alexandria in the library, and 30 years of IVF in Alexandria Library, again, as you can see here. And in between, there were a celebration for 20 years of IVF in Marrakesh in 1998. As you can see the picture with Professor Edwards and Professor Hans Evers who was the chairman of ESHRI at that time. And here is the celebration of 30 years of IVF in Alexandria, 2008. He received, of course, the Nobel Prize in 2010, but by that time he was too ill to receive the prize, and it is his wife who went to Stockholm to receive it from the king. So, if IUI does not work with controlled ovarian stimulation, then we can consider this as an unexplained infertility, really, because by that time we must have, if we have a problem in the sperm, of course we have to go to ICSI, but if we don't have a problem with the sperm, it is always better to divide our oocytes into two. One of them, one half you do IVF and one half you do ICSI, and it will tell us if there is a problem in the fertilizing capacity of the sperm. And as said, if we do IVF, so what are you going to do? From the beginning, we will do antagonist protocol. We will trigger with the GnRH agonist protocol, as we can see in the lower panel here. And we will do freeze all of the embryos and put them back in a subsequent cycle. All this to prevent ovarian hyperstimulation syndrome. And there is some evidence that if you do this, you increase your success rates. There is also the laparoscopic ovarian drilling. People thought this was introduced in Norway many years ago. It does have advantages, but it has also risks. The advantage is that it restores ovulation, but only for few cycles. There is no risk of multiples, of course. It can be cost effective if your IVF is very expensive. And if the patient does not ovulate on her own, she will respond easily to drugs to induce cell ovulation. But on the other hand, we have risks. The surgical risks like the anesthesia, infection, and so on, injury to organs. We also have the risk of developing adhesions and scarring, and the risk of ovarian damage. If the doctor is too enthusiastic and has done many drilling points, this can destroy the ovary. In fact, there is the rule that not more than 4 drills in each ovary. And then, of course, it is only a temporary effect. As said, we do it, the patient may ovulate 3 or 4 times, and then she will get back to her previous irregular cycles and ovulation. And of course, we shouldn't forget the long-term effects. As you can see here, what should we do for this? Lifestyle modifications, healthy weight, balanced diet, exercise, managed stress, good sleep, medical intervention, birth controls, control pills are set to offer good protection in the future. Insulin sensitizing medications, anti-androgen medication, cholesterol-lowering medications, and finally, regular health monitoring for diabetes, cardiovascular, endometrial, and the mental health support. So, in conclusion, ladies and gentlemen, PCOS is a syndrome. It's not a disease. And these PCOS patients have a high serum level of AMH, probably dating since fetal life. And this AMH acts by inhibiting the aromatase enzyme system, leading to disturbed ovarian function with all the anovulation, infertility, and so on. This is also reflected in conditions more commonly seen in men, like hirsutism, metabolic syndrome, insulin resistance. The treatment of PCOS depends on the symptoms. While infertility should be treated by ovulation induction with or without IUI. Failing this, IVF with or without ICSI should be done depending on the quality of semen, and in all cases, measures should be taken to guard against the development of ovarian hyperstimulation syndrome, and the long-term effects of PCOS should not be forgotten. And with this, I come to the end of my presentation, and I would like to thank you very much for your attention.